Hello, I'm Bob Kocher, and welcome to day two of Moonshots for Health. So excited to talk to you. I think a ton about the future of healthcare and how we can make healthcare better faster. And I'm thankful for the work that you all do to make healthcare better faster. What I thought I'd do today in my remarks to you is talk to you about some of the thinking I've been doing over what are the big problems that we need to tackle to make healthcare better for the next decade. I recently wrote an article in JAMA with Rahul Rajkumar, who many of you will know, thinking through what are the big issues that we need to tackle. Rahul, for those of you who know him, know that he's one of the leading thinkers around innovation and was one of the pioneers at the Medicare Innovation Center, thinking about new payment models, went on to North Carolina, where he was really at the leading edge in the country for creating value-based payments and really innovative approaches to improving outcomes. When we stepped back and said, what has to happen, we thought about really three important challenges that we need to focus on. One is helping to make healthcare increasingly more affordable. Healthcare, unlike almost any other part of the economy, has seen prices grow faster than everything else except for higher education. And that's meant that all of our cost sharing is higher when you go access the doctor. If you get sick, you'll have to pay more out of pocket. It means that more of your wages are going to pay for your health insurance and for other things. And so affordability is really, really important. We're seeing it acutely with medications. Medications, including insulin, can cost thousands of dollars out of pocket for patients. And so you hear horrible stories about people having to stint on their medicines or cut them in half or delay refilling them. And that's sort of something that you shouldn't have happen in America. A second big challenge that we have to work on is actually getting our money's worth for healthcare. So really the quality of care. It pains me that when you compare the US to other countries, we come out sort of average. We seldom do better. And that's astonishing because in America, we have the most innovative biomedical research infrastructure. We have the best hospitals. We have extraordinary medical training. We pay more than anybody else. We get the new technologies earlier. So one would think that we ought to live longer and be healthier, but we don't. And that's really troubling. In some particular majors like chronic disease care, like diabetes, we duke it out with Costa Rica on diabetic control, which seems needless in a country that has every advantage that you can imagine. Even worse, you look at quality by different socioeconomic levels or ethnicities and races, and we do worse when you look at subpopulations as well. So there's a giant opportunity to make the quality of care better, and probably all of you have seen what it can be. We all know that with the right clinicians in the right care model at the right place, we can deliver the best in the world. So how do we do that more often for more people? Then the third big challenge that we have to get better at is really around disparities in care. Ever since I was a medical student, the Dartmouth Atlas was publishing giant differences in what healthcare costs and in the quality around the country. Regrettably, we haven't made as much progress as one would hope. With COVID, we've seen it more acutely when you look at pockets of America where we have higher mortality, or different racial or ethnic groups where we have higher mortality, we have less access to testing and vaccinations. And so we have to do a much better job on making sure that all Americans have access to really the best care. I do think we've made enormous strides in these dimensions. Over the last decade, we've seen 45 million people gain access to insurance. That means that many more people can access care. We've seen out-of-pocket protection, so you can no longer go bankrupt, hopefully, if you have an expensive medical event because of out-of-pocket maximums in health insurance on an annual basis and no lifetime limits on what can be covered. On quality, we've made some improvements in quality for sure. Notably, we invented COVID vaccines faster than anybody thought was possible, and these vaccines are better than people would have expected, so that's incredible. We do really well for preterm babies, for many cancers, and so we've cured Hep C. So there's been some really big improvements over the last decade in quality. But when you look at the things like high blood pressure control or mental health care treatments or preventative care or type 2 diabetes, we really haven't made as much progress as one would have hoped or expected, I think. Then on disparities in care, I think the story's pretty mixed there too. We're beginning to pay for efforts like social work to help people access social services that they're entitled to. Some of the Medicare Advantage plans are beginning to think a lot about food security. Some of the commercial insurance companies like Blue Cross Blue Shield of North Carolina and Blue Shield of California working on homelessness, but there's a bunch more work that can be done. And certainly for access to care, there's a lot of work that can be done to make sure that patients on Medicaid can access both primary and specialty care conveniently in their communities. And I hope that telemedicine also makes it more possible to deliver excellent care to populations that haven't been as well served in the past. But with this as context, I've stepped back and said with Rahul, well, what do we do to actually make progress in these areas? So I want to share with you four things that I think we should be paying attention to that I think will really unlock a bunch of the opportunity that exists in the areas of affordability, quality, and equitable access to care. The first topic is we need to invent value-based payment models for specialty care. Over the last decade, well, really, over the last 50 years, we've experimented with payment models, but most of America exists in fee-for-service healthcare. Over the last decade, with the advent of the Affordable Care Act and then a subsequent law called MACRA, many new payment models have been created to support primary care doctors to move into models of care where they have some sort of budget that they manage on behalf of their patients to deliver all of their healthcare. And if they deliver the care more efficiently, they can make more money. If they deliver care less efficiency, they could be on the hook for it. And it makes sense to start at primary care because that's where care begins. And so you want that clinician to be conscious about sort of downstream costs of care. The problem we have is that after primary care, the next thing that happens usually is specialty care, then hospital care, and then after the hospital, rehabilitation or post-hospital care. And once the patient leaves the primary care doctor's office today, almost all of that care is in fee-for-service. Fee-for-service is a way of paying for healthcare that has a lot of advantages. It rewards the clinicians for doing whatever they think the patient needs. It means they get paid for it. It incentivizes them to deliver options and access to all kinds of patients. It is easy to pay for because you pay per unit, so you don't have to develop complicated ways to sort of figure out what's in and what's out. But it also leads to sort of excessive cost. And so what we do today is we have spent a lot of time getting primary care doctors to embrace value-based care models like accountable care organizations or capitation or variations of those too. But once the patient leaves, they go into a fee-for-service system that's really not thinking about the cost, it's thinking about doing more things to the patients. And so if we want to have the system act kind of in harmony and not be at odds from an incentive perspective, we need to now invent value-based care for specialists. I think there's a bunch of ways one can do that. You can think about it at the level of a disease where you give a specialist a budget for a year of care for that disease. You can think about it around an outcome that's achieved and then having shared savings across primary care and specialists for achieving the outcome. You can think about basically paying for a certain number of hospital beds per population and then having the hospital think about how it wants to use those bed days. So there's a bunch of ways to do it, but I think that's where we need to invent some new models, because the more we can get the primary care doctors, the specialists, and the hospitals all trying to achieve the same outcome most efficiently, the more productivity we'll have in the system, and frankly, the better experience and better coordination we'll have for the patients. So that's number one, value-based payment models for specialty care. Number two, we need to learn how to reward multi-year investments in health. One of the tyrannies of the US healthcare system is that everything is a one-year cycle. Whether you're in a value-based payment model as a primary care doctor, you have a budget for 1 year for that patient, and if that patient costs you less than that over the year, you make money. If it costs more, you don't make money. The same thing goes for all insurance products. Patients can buy a different health plan every year, or at an employer, you renew every year, and perhaps in the same health plan. But that means that investments made to make you healthy need to therefore pay back in that basically same year that you're in the health plan. And that leads to short-term thinking and how we think about patients' health. And you might say, well, that's how we do things in America. We think about quarterly earnings for companies, so it's very short-term. The problem with health is that it takes a long time sometimes to see the improvements. So imagine you could cure diabetes, but you had to pay some money in year one to do it, but they didn't have it for the rest of their life. Well, we know that diabetes over someone's life will add $50,000 or so onto their total healthcare costs, but it might cost a couple $1,000s to reverse the disease in year one. Today, you need to be thinking carefully about whether or not you'll pay the money in year one to avoid $50,000 of costs later, because those cost savings might go to somebody else. Fortunately for diabetes, in the case of Verta, the medications we get people off of are very expensive, so that can more than cover the cost of the service. But the person paying often in year one to reverse diabetes is basically accruing a whole bunch of value to somebody else in the future, and that's really hard. It's even harder, though, for things like pediatric diseases, asthma or type 1 diabetes, high blood pressure. These are hard things to pay for making better because the benefits don't really accrue for years later when you have healthier adults that aren't having heart attacks and aren't having early cancers. And so we need to have some way to connect the dots between making investments today that are really in the interest of health and those who have to pay for it today when the benefits are coming much, much later in the future. People often ask me, well, Bob, like, why don't we see lots of venture capital interest in things like better nutrition or better sleep or more exercise or mental health care screening and prevention or drug treatments or even high blood pressure control? And that's not because they don't have enormous benefits on health and savings in the future, but it's often because the savings don't come quick enough. And so there's a bunch of, I think, creativity that can be brought to think through how we basically reward those who make the investments for the benefits that come later in health for people. And that can be done through health bonds or escrow accounts where the savings get paid back to those who made it. They can be done through sort of long-term contracts that one might have with the partner delivering it, but that's a second area where a lot of improvement could come. A third area that could really make a difference is to create some alignment across payers for how all these value-based payment systems or quality improvement programs work. In America, we made a choice, a design choice, that we could have lots of insurance companies offering basically financing of healthcare to Americans. And so we have the Medicare program for old people, but that actually is two programs, Medicare and Medicare Advantage, and then in Medicare Advantage, a bunch of variations. We have Medicaid for those at lower income. And then we have the commercial insurance markets where we have many, many payers. And we've made a choice in America that it's great to give you a choice whether to buy Aetna, Cigna, United, or a Blue. The hitch is that they all have different ways of paying doctors and of defining quality and doing value-based care payment arrangements. And so if you're a doctor, you might see 40 or 50 patients a day, and you'll probably have between 15 and 20 different payers paying for the care. All of the payers care deeply about making sure that their patients have access to care, that the quality is good. They'd like to have the doctors improve the care for their patients. And so they all ask doctors to report information back to them about how they're doing. But they'll define differently what metrics they want to collect. They'll define differently, like, what are the goals we're trying to achieve? They'll define differently what is success on the outcome. They'll have different partners that you might want to work with. Some payers may want you to use Virta and refer patients to Virta because they're experts in diabetes. Others will have other programs. And so as a doctor taking care of the patients, it's awfully confusing what you're supposed to do and how to do it. There's a lot of cost that actually is borne by doctors and health systems to collect the data that's asked for by the payers. Payers spend a lot of time looking at that same data, trying to figure out how it's going, and then sending notes and reminders to doctors. But it's all really confusing. And if you're practicing care, you basically just do your best every single time, and you can't keep track of all the models. Behavioral economists would say, well, wouldn't it work better if we had fewer things that we're paying people against and make them always the same so you know exactly what they do? And the answer is probably, of course it would. And so efforts to get all payers to sort of have the same things that they're paying doctors to do over some time period would make a big difference, I think, in the attention paid and hopefully the benefits gained by patients by virtue of aligning models across payers. The government can do a lot to catalyze this. Medicare and Medicaid together are the largest payers in the healthcare system. And so if they simply got on the same page, that would help. But certainly the commercial payers would need to buy in too, because they're the ones who pay the highest prices. And so the highest margins come from those payers. So having them involved will make a big difference too. The fourth thing we need to tackle is administrative burden, particularly for quality metrics, as I just said, but also risk adjustment in American healthcare. The way we pay doctors in value-based care models logically makes adjustments for how sick a patient is. So you don't get the same amount of money for a young, healthy person as an older, sicker person. And that's really important because we ethically want to make sure that the sickest patients are also just as attractive and desirable for doctors as the healthier patients. And I can tell you, like, on the one hand, I think the current model might actually make the sicker one slightly more attractive. And so I think that's a good thing, that we want to deliver care to sicker people. The challenge is that the way you prove that a patient's sicker is by writing down more stuff about the patient and doing it every single year. And effectively, the more you write, the more you can derive codes called HCC codes that are used to sort of then increase the payments to doctors. And so in a value-based payment arrangement, if you're a doctor, you spend a lot of time writing down diseases about your patient so you get paid properly, fairly, and more for taking care of those patients. You also spend a lot of time making sure that you report properly the quality metrics because you get bonus payments for those as well. Some people will say it takes about a half of FTE per person full-time per doctor to do this amount of work. And so if that were true, that's about $50 billion of labor costs just to sort of collect the data and metrics we use to pay doctors the right amount and then to see if the quality of care is good. One of the things that one would have hoped would have happened with the widespread adoption of electronic medical records and computers everywhere is that you could build actually data science models to automatically extract that data, to automatically remind doctors for what to do. And for risk adjustment, use things like lab values and medications as opposed to what I write down to figure out what proper payment is. It makes no sense today to patients that it's so complicated to know what's covered, what's reimbursed, and even how are they doing in their healthcare. It makes no sense that it's hard today to exchange information across providers. It doesn't make sense that we use fax machines. There's a whole bunch of stuff that can be done to get rid of the overhead of healthcare. And when you kind of step all the way back, that's about 20% of the cost is actually just in the administrative aspects of how we deliver care. So if we could chip away at that, we would actually make a big dent in the affordability of healthcare without having to change anything about how we deliver medications or make any limitations on sort of the actual care that people get. So as I step back, I think there's 4 giant problems that we should be focusing on for the next decade. One is coming up with value-based payment models for specialists so that specialists have all the same incentives to be value conscious as primary care doctors. The second one is to reward multi-year long-term investments in your health and come up with payment mechanisms to reward the people who take the risk up front to pay to make you healthier in the future. The third is to get payers to work together so that the payment models are rational and make sense and are not idiosyncratic to every single payer. Then the last one is we should all work together to get rid of the overhead of healthcare because it makes no sense to have healthcare not get the same productivity benefits that we see in every other sector from technology and to get rid of a lot of the writing and documentation that doctors do today that doesn't make care better, but takes a lot of time. I'm very excited for what I think will be another decade of remarkable improvement and innovation in care. I'm really happy to know that there's companies like Virta that can deliver outcomes for diabetics that people hadn't thought possible. And that we have so many patients today that talk about how well they're doing. It makes me feel proud. I'm excited that we're thinking a lot more about mental health care and access to mental health care benefits across the country. And I'm excited that we're thinking about how to make healthcare more accessible and affordable for all Americans, because that will help us have better health and better lives. I thank you so much for your time. I hope that you have a great rest of your day at Moonshots for Health.